So I'll do a quick greeting and welcome to those of us that are just getting dialed into the call. Got a number of folks that are joining here, so hopefully folks can hear me. My name is Zach Heider. I'm the president of Hubble Communications, and just like when you get on an airplane, you should confirm that you're on the right flight. This is the Better Communities webinar on lessons from the front lines, how COVID is changing healthcare communications. I'll do panelist introductions here in just a second. I'll give our audience here another 30 seconds. There's still folks kind of rolling in, and then we'll go ahead and get started. Claire, just a quick check. Can you hear me okay? I'm just waiting for the hand signal.
Yes, I can hear you.
Great, thank you. All right, we're going to go ahead and get started. Folks may join as we go. I know it's the Friday before a holiday weekend, but thank you guys for all joining. It shows that there's a very strong interest in this topic. We've had 50 or so register and about as many participating today. So let's go ahead and get started. I want to begin just by introducing the four panelists that are going to be part of this discussion today. Allison Taylor, she is the Director of Strategic Communications at Peace Health up in Vancouver, Washington. Peace Health, of course, doesn't just work in Vancouver, they're regional. They're all over Oregon and Washington. Brian Terrett is the Director of Public Relations and Communications at Legacy Health Systems and has my favorite headset of any webinar participant that I've had yet. So very jealous, Brian. Paseth Pitch is the Public Information Officer at Hillsborough Fire and Rescue and has already forewarned us that if the alarm goes off behind him, he may disappear during this webinar. Such is the job when you're on the front lines. So Paseth, great to have you. And last but not least, my good friend, longtime collaborator, Jess Colombo. She's former digital comms from Oregon Health and Sciences University, now the founder and CEO of Tiller Marketing. They do a lot of work in the healthcare space, and it's great to have all four of you be part of this discussion. I told the panelists today that I wanted to give each of them just a brief opportunity, each of our public information officers, a brief opportunity to talk a little bit about how this crisis is changing how providers and first responders are communicating. And I want to begin by just handing over the mic here to Brian and give him a few minutes to just talk about Legacy and the work that you guys have been doing, how you've been managing your way through things. And the floor, Brian, is yours.
Thank you, Zach. I really appreciate it. I really want to talk about three different lessons that we've learned over the past 83 days. In fact, we just closed down our Emergency Operations Center yesterday after 82 days in full nonstop operation. So it was a good time to sort of sit back and reflect on the things we learned. And there are three things, if you could bring that up on the deck, that'd be great. 52.4 PDCA and Talent Scout, and all of those things mean something particular. 52.4 is, from my perspective, is the fact that this was not only a marathon, it was a double marathon. And we've thought about this from the very beginning about the fact that this was not going to be something that was going to be over soon, because you could look at where it was happening around the world and you could see this was going to be a long-term thing. And we didn't know what the surge was going to look like, and we wanted to make sure we were prepared for it. So one of the first things I did was I looked at my team. I have a team of 3 people. And the first thing I did is I restructured the team in a way that allowed us to ensure that people remained healthy during the period. And we did that by creating 3 different positions. One was a proactive media, where a person was able to think about COVID-19 related stories and look at ways to pitch those out to tell our story. The second was reactive media, where essentially one person for an entire week would just be taking incoming calls from reporters and trying to address those calls. And the last position was in the Emergency Operations Center, EOC person. And I specifically designed it so the person who was coming off of reactive would go into the EOC as a way to almost recover from what was pretty much an intense week of a lot of work that they were doing. It also gave them a chance while they're in the EOC to see what was going on within how we were responding, and think about it in terms of how can we pitch those as proactive stories. So when they came out of the EOC, they went into the proactive position. So that, I believe, helped us survive the last 2.5 months in a way that nobody announced that they were going to quit and nobody got burned out. So that worked pretty well. We talk about PDCA. If you're familiar with lean terminology at all, PDCA stands for plan, do, check, adjust. And one of the things we realized immediately with the positions that I created was a lot of the proactive stories weren't just a week long. And initially we had decided to hand off those proactive stories to the new person who's coming in on Monday. And that just became really awkward. And because you're out there, you're pitching, you're talking to people, you have relationships with reporters. And so it made a huge difference to make that adjustment so that a person who was doing proactive was able to carry those stories forward. And what that resulted in is some really great coverage. We're really pleased with a lot of the local stories that ran. One of the stories that we were trying to develop with NBC Nightly News and the Today Show was the story of an expectant mom. And she did a video diary of herself from the beginning until she gave birth. Sadly, there were some changes at NBC, so they weren't able to do that. But KGW quickly picked up that story, so we got that set. In addition to the national coverage we got for the 14-year-old PEDS patient. And we just recently are in the process of finishing the story with the Wall Street Journal about our BICU observers. And that's a long story I could spend a half an hour talking about, but I won't. So that was the success that came out of that. And then finally, Talent Scout. And what I mean by Talent Scout is we learned fairly quickly that if you look at the people within your organization, they may be doing different things, but when it comes time to think about any kind of a crisis or a disaster, you can turn to various people within your organization to pick up roles that they otherwise would not be expected to do. And I'll give you 2 examples. One, Thelma Hale, who is a production assistant, and she does project management for our creative services team. We were able to get her on board on our team, and believe it or not, in 2020, Legacy Health still uses a pager, and we find it very effective because we give reporters one number and they know where to call. So Thelma essentially became the pager wrangler, and she, on a daily basis, was able to pick up those calls, contact the reporter, find out who they were, what their deadline was, what they were, and then she dispatched those to the reactive or proactive side of the team. In addition to that, Mary Pat DeGroot, who is on our digital team, she joined us and essentially became the conduit between the public relations team and our digital team. And so she was able to hear what we were doing on a daily basis, connect with the digital team, help inform them what we were doing, so that as they were doing their planning on a day-to-day basis for digital, they were able to keep that pipeline completely filled. So those are my 3 lessons, and I'm looking back on this fondly. I will say this: the last major crisis I was involved in, I was working for the city of Eugene when the Thurston High School shooting occurred. That lasted for 2 straight weeks, working probably 20 hours a day. I knew early on when I thought about the COVID-19 crisis, it would be a completely different crisis. And so, we were able to make those adjustments. And I think flexibility really is the key word.
That's it. Yeah, that's a good word, Brian. Paseth, I want to hand the floor to you here and obviously introduce the fact that you're looking at this from not an entirely different perspective, but definitely further up the front lines. You guys are the responders that have been out there on the front lines of this. So want to hear from you a little bit of your thoughts, observations, and some of the things you guys have done in the last few weeks.
Yeah, Zach, thank you, and happy to be here with all of you. Similarly to Brian, I'll lead in by saying, COVID-19 really tested our own emergency operations plans. Folks sometimes don't think that fire and EMS have those types of contingencies in place, but things escalate quickly and things can change in a heartbeat. That meant most obviously from the front lines, it was enhanced PPE that included gowns and masks, gloves, iPro, that in some cases went all the way up to a level B hazmat suit, fully encapsulated. Beyond that, from a response protocol standpoint, we moved to what we call a greeter model, where for most EMS calls, the crew would enter into someone's home who was experiencing a medical emergency together, but using the greeter model, the lead EMT or paramedic would actually go in full PPE first. The crews would maintain physical distancing, and then they would make their assessments in essentially two different places. And that was for both the safety of the patient and the safety of the crews. They then followed their algorithms to make sure that the appropriate interventions were being done, and they were gowning up or gowning down as needed. Both of these really, as I mentioned, presented stark differences in the way the public perceived us. And in some cases, it's kind of scary to see our first responders looking differently than they might have been used to them in the past. We also, because Hillsborough Fire and Rescue is a department of the city of Hillsborough, established our Emergency Operations Center, and that was set up here at Cherry Lane Station 6. So that gave me a direct line of contact as the PIO, not just for Hillsborough Fire, but for the city as well. From a communication standpoint, it really meant a few things, starting with our internal comms. We predominantly, as I think a lot of organizations, rely on email. It meant that we needed to adapt and be a little more agile. So we use something called Mondo pads, which are essentially large TV monitors in all of our stations. And we do daily video briefings using that, similar to Zoom. Those were 2 to 3 times a day, depending on how quickly information was being delivered from our regional and healthcare partners outside of fire and EMS, and then of course at the state and federal level as well. And then we would supplement that with Microsoft Teams, our other learning management systems, those tools that our firefighters and first responders were used to give them more details or reference points for what couldn't be covered in detail on a daily briefing. From an external comms standpoint, the 80-20 rule applies to the fire service in the sense that really 20% of our communities call 911 and have a direct experience with our crews. The other 80% tend to kind of live vicariously through that 20%, and they can form their opinions based on how we handle some of those calls. So our outreach strategy is to do community events, open houses, station tours, station visits. And so we try to capture the rest of the community that might not have an opportunity to experience us during emergency, which is kind of the best case scenario, if you will. That elevated our focus on reputation management because, typically our firefighter EMTs and paramedics, as much as they're highly trained, highly capable, have equipment at their disposal, the pandemic really demonstrated an immense strain on our PPE, not just for us, but of course our hospital-based healthcare partners too. So now we've turned to asking for help from the public. And the initial concern was that trust and confidence might be eroded, but in fact, it uncovered just an immense amount of empathy, and the response was swift and overwhelming. So we really appreciated that from the general public. And all of this really came to highlight for us too, and this is the biggest takeaway, was that our employees, whether they're frontline or support staff, day staff, but they're all humans, and they're concerned about their own health and safety, and largely they're also concerned about the risks associated with going home at the end of their shift and exposing their families to that. So we made a special effort to make sure that we were communicating often and as openly and multiple channel as possible, not just with our first responders, paramedics, and firefighters, but also with their families. We opened up phone lines. We opened up our management team, myself included, made ourselves available for direct phone numbers, phone calls at 24 hours a day, just in case folks had some questions or concerns. And then finally, our peer support team, which is made up of mostly first responders, but other administrative staff, really stepped up to make themselves available too. So it was a full-throated effort, as the rest of this panel can attest to, and we're really happy to be part of this larger system of care.
Well, thank you, Pasath. I mean, I think I speak for everybody listening that, thank you for your service and your team and what they do every day. So thanks for kind of giving us that overview. Allison, I'll leave the last few minutes here to you and let you talk a little bit about what you guys have been doing at Peace Health through this.
Great. Thanks, Zach, and thanks so much for having me. Similar to the lessons learned and the stories that Brian and Pasath shared, very similar experiences at Peace Health. I think some of the highlights and lessons learned that I'll be sharing are really about an integrated system across 3 states. If you want to go to that next slide, Zach. Just a little bit of grounding in what Peace Health is, with 10 medical centers and 164 clinics across 3 states. Things got complicated quickly with COVID and really required a lot of coordination across our organization. So that's kind of the breakdown of where those medical centers are in different cities in those states, each broken down into a different network. And then we have a series of medical group locations, the clinics, throughout all of those facilities too. So while Peace Health is really seasoned and comfortable with a hospital incident command structure, COVID was really the first time we had 3 network incident commands stood up, as well as our system incident command. So our system office is in Vancouver, Washington, and the Marcom marketing and communication team is spread out across all 3 of these networks. So while I have a team that is helping support all the communication efforts from Vancouver, there's also a team embedded in our Columbia network in the Longview and Vancouver hospitals, a team embedded in the Northwest network in those hospitals, and then the Oregon network in those hospitals. And we're all peers of one another, and the goal was aligning those hospital incident command structures to be having similar messaging and alignment across those. If you want to go to the next slide, Zach. That was really the first hurdle that we needed to tackle when all of our incident command structures stood up. What did that look like? It was something we hadn't done before. While we understand how to do one incident command in one facility and we're well oiled and seasoned with that, that seems normal. What do you do and how do you make it work when you have one in each location? So first was really the meeting structure and the cadence. What did that look like so we weren't overlapping each other? In that PIO role, serving on each of the hospital incident commands. We can't be in a network incident command and a system incident command at the same time. We can't be pulling from the same resources and expecting that to function smoothly. So the first goal was really the setting up the meeting structure and that cadence. Next was the issue escalation process. What does that look like when you've got the networks reporting issues up, because they're the hospitals, they're the medical centers, they're the clinics, saying, here's the issues we're experiencing, and how do you triage those from the system level to impact everyone uniquely and in their markets. And then finally was creating a communication feedback loop from that. So if issues were escalated from our networks to our hospital incident command structure and they were resolved, how did we get that information back in a timely manner? So similar to what Seth was sharing about, relying heavily on email communications, while that's our bread and butter, the standard of emailing, we knew that things were changing so rapidly that wasn't going to cut it. So in addition to email communications, as a part of that communication feedback loop, we stood up a dedicated intranet page for just COVID-related content. We printed out daily updates and created COVID boards in each of our medical centers and clinics where the communications were printed and posted on the boards. Brian mentioned the lean practicing and the lean way of thinking. So our daily management system, our DMS boards, where all the leaders and caregivers huddle every day. What are our top priorities? We made sure all of the COVID-related topics were included on those daily management boards and run through every day. And sometimes it was multiple times a day. Something in the morning that we communicated was different by the end of the day. And so it was multiple channels of repetition, getting those pieces of information out. And then just to touch a little bit on the external side of that, we also launched a microsite on peacehealth.org with 15 different community landing pages. So all of the information we were sharing internally through this system and network incident command structure, we knew we also needed to share uniquely externally in all of our communities and markets. So the microsite was really the landing page for all of those patients and community members to find out what was happening and how could they get the care they needed. So next, Zach, if you want to bring up those next bullets, was, so I like to think of that first part, this is the network incident command systems, as how were we coordinating all of the efforts? And then next was really what. With 3 different states, we had to align our messaging and our communications with multiple states, multiple governments, public health departments, hospital associations, all having different viewpoints and standards and requirements and regulations and recommendations for how to handle COVID. So our network teams, teams embedded in each state, as well as our system team, were plugged into all of those channels. And it wasn't just our Marcom team, of course. It took, coordination and support from our operational leaders, our government affairs department, reviewing federal waivers and state actions, our quality team, our legal team, employee health, HR, embedded in all of those, and then bringing the information back up to that hospital incident command structure to then disseminate the information out. Because of the complexity of that, it really led to varied messaging. So one example would be broad messaging that applied to every single facility was the COVID screening process for patients. How are we going to screen? It was the same screening process for every facility everywhere. System-wide messaging, everyone implemented it the same way. To the other side of that, which was hyper-localized messaging to reflect the community and the environment in that community. An example of that would be our COVID patient volumes. While we were supporting an outbreak at a skilled nursing facility in Bellingham, Washington, at that same time, there were no cases in Alaska, no COVID cases whatsoever. So the mentality of our caregivers and the community members experiencing COVID was very different. So the same messaging wouldn't have resonated about patient volumes in those communities. So the messaging had to be really hyper-localized. And then another example of that would be readiness. Some of our communities were bigger and being impacted quicker because of the population. And so they were standing up triage tents outside of the EDs in order to help safely process patients, while other communities didn't need that. So just really a lot of variance between the messaging based on the community. And then finally, I think what was not necessarily a lesson learned, but just always something that grounds me is sharing kindness. This was really a joy throughout COVID. If there is a joy, it was sharing kindness. 8th grade students at a middle school in Battleground were learning about poetry when they were put into quarantine, and they submitted a book of 33 poems to Peace Health Southwest in Vancouver. And it just warms my heart. And these are the types of stories that we would take and share internally for our caregivers to feel really valued and know that the work that they were doing was being seen, and also externally to share the good news and the heartwarming feeling that was permeating through our communities for all the work that was being done, similar to what Seth was sharing.
Well, that's a great way to end. Thank you for sharing those insights, and really just amazing work by all 3 of you. I want to transition us to talking. I mean, we're all in this sort of news business to some degree. We're trying to sort of react to, respond to, and manage the news cycles, which seem to be getting ever shorter. This feels like it's been a very long news cycle, even though there's been cycles within those cycles. So what I thought I would do is, for the last portion, the last half of this virtual panel, is just get your guys' reaction to some of the headlines that we've been seeing, both at a national level, but I think also too at somewhat local level here in Oregon and in Pacific Northwest. And Jess, I'm going to start with you. One of the things that I know, and I had a great conversation with Becky Holtberg over at the Hospital Association the other day. One of the great challenges now is, obviously hospitals have been trying to keep people out who are not COVID patients. And now we're in a position where we want to get people back. And there is a great challenge in the messaging art of helping people understand that if you have chronic disease that needs treatment, consultation, medical advice or care, we want you to come back to the hospital, but many are afraid. And Jess, I'm just interested in sort of your perspective as somebody who's out there dealing with a lot of the messaging challenges around this. What are your thoughts about what it is that hospitals need to be doing, and how have you seen hospitals get out there and say, look, we want to bring folks back into our buildings again?
Yeah, this is a delicate dance that we're doing in real time. And I think the second wave, that's not an if, it's a now, that's already building, is this combo of chronic condition patients who are waiting until the last minute or before it's too late, and we're not able to give them the care. I work with a lot of community clinics, FQHC, private practices who are saying, I'm just getting somebody in the nick of time to make sure that that didn't go sideways in a really bad way. So it's the chronic condition. We've got the mental health surge happening. We've got provider shortages coming hard because nobody signed up for this kind of experience in healthcare. So early retirements and people dropping out of med school, and a really fascinating dialogue, if you're not following it, #MedTwitter, is the weight that I carry emotionally, is the practitioners having a dialogue amongst themselves. And then you've got people who really needed a haircut this week. So the surge is coming in a big way. And my clients, the ones that I've been really impressed by, are just continuing the really hard work in the content marketing space and in the advertising space, or just public information space, to prep messaging that we're gonna need in the weeks and months to come. So how do we make sure it's easier for people to access telehealth? How do we make sure that everything's translated? How do we make sure we're doing direct mail? I'm a digital consultant, and I'm doing radio PSAs and billboards right now, because this highlighted a really, really dangerous gap for us, that there's a lot of people that just don't have the access, and that's not gonna be negotiable in the next few months and in the next 12 to 18 months. So I'm seeing a lot of people double down on content marketing, and a lot of video we're shooting to show people in clinic safely distancing, masked, and thought leaders are providers that are standing up on camera and saying, here are all the precautions we're taking to make sure that you and your family are safe when you walk in our doors. And that, I've been really impressed by folks that are continuing to invest in content marketing right now.
Yeah. Allison, Brian, I mean, at your hospitals, I mean, how are you guys dealing with this? Because, I mean, this has huge implications to long-term healthcare, other pressures that will come to the system downstream if we're delaying a lot of, important care now that's not COVID. So I'm just interested, Legacy and Peace Health, I mean, how, Brian, I'll start with you. How have you guys been dealing with trying to explain to people, look, we're reopening and you can come back in for care?
We're doing sort of a typical response, in the sense that the first effort was doing earned media. Dan Bissell, who is the medical director for our emergency department practice group, we got him in front of as many reporters as we could to talk about adults coming to the emergency department. We were specifically seeing issues related to stroke and heart attacks. There were a number of sad cases where people had had a stroke, and if they had responded sooner, they would have had better outcomes, but we're having worse outcomes of that, and because they delayed the care. And so, we wanted to get out there as early as we could with him. We created as Jess said, we created a video. We've got a video on our website. We've shared the video with the Washington State Hospital Association and the Oregon Hospital Association, so that they can send it out and have all the members use it. And then we heard from Randall Children's Hospital, from their emergency department, that they were really seeing some sad things, in the sense that parents were bringing children in who had broken limbs, and they had waited for care so long that the limb had started to heal. And they had created a situation where a child was, in worse shape because of that. In addition to that, we're seeing it with well child care. And so again, we've got a great video showing the Randall ED in terms of how it's safe, and how people can come in and what they can expect, and how we're making sure that they're taken care of. We're using it through earned media, where we've created the video, where we are doing a direct mail. We have about 500,000 people on our direct mail list who are getting the videos, encouraging people to come back.
Allison, thoughts?
Ditto to what Brian said. All of those things, I think looking at all of those different channels. Another to add to that is partnering with the Washington State Hospital Association on their campaigns and making this more about care in general. This isn't about Peace Health. This isn't about legacy. This isn't about OHSU. This is about get care at the facility you need, and wanting to focus on our communities and the wellness of our communities. I think another piece, an important piece of that is that we're working on at Peace Health is our 16,000 caregivers are patients themselves, and really encouraging them to take care of themselves by instilling the confidence and trust in them in the system, that they are not going to get sick when they go to their provider, that we are safe and open and ready. They will instill that in their own families and spread that in the communities. They are our best advocates. And so we're working on really robust internal communication campaigns around that as well.
Seth, I want to transfer to you, and this is a specific topic for the frontline first responder conversation. And OPB did a really interesting story. This is probably from a month ago, so a little further upstream in the crisis. But just looking at how across the Pacific Northwest, folks in your line of work, the rescue teams, the responder teams, ambulance crews, et cetera, they had to invent their way through this. And I'm just interested to know how you guys have responded to some of the questions around how are you navigating your way through shortages in PPE, and explaining the roles of fire departments traditionally and fire departments in a pandemic.
Yeah, the quote there, necessity being the mother of invention. Largely our firefighters and first responders, it's kind of inherent to the job. I've seen paramedics feed an O2 tube through a teddy bear so that they can provide blow-by oxygen for pediatric patients, so that they can keep them calm and then have that medical intervention. The one thing I do want to share for the audience is that across the nation, most fire departments are actually volunteer. And there are, the coasts and larger urban areas will have professional career staff, or sometimes combination with both. And I think one thing to point out is that, in a dense urban setting where we're lucky enough to be, our resource cache might be, a little bit better suited to last longer versus maybe a rural fire department that doesn't have the same level of resources. So, that function alone then kind of dictates, how long you can use your existing PPE. Are there regional systems in place for obtaining more? So we initially, our primary focus was on extending the use of our PPE, the gowns, the masks in particular. Can we disinfect those items, still providing protection for our responders and our patients? And then, the county and the state's EOCs then really came into play when the emergency caches were able to start distributing some of those things. One thing that I think all of our community members around this region in particular can really feel assured by is that we have mutual aid agreements in place, and we have strong relationships with our neighboring departments and agencies. So, the right care for the right patient at the right time really looks like the closest unit. So you may live in Hillsborough Fire and Rescue Service area, but you might actually get a closer responding unit from Tuolumne Valley Fire and Rescue. So I think all of those things and the development and establishment of those relationships and those kind of processes early on helped us kind of navigate some of those shortages a little better.
Yeah. Well, let's talk a little bit about, and this, Jess, I know is an area that's of particular personal passion and interest to you, which is just mental health. There was a great story in the Oregonian about this, that, there is, a lot of celebration and gratitude going towards healthcare workers who have been in those emergency rooms and in those ambulances and dealing with, sick patients. But that now there's this issue of that stress and the conditions under which, our healthcare force has been working is leading to some mental health problems. So Jess, I'm just interested in your sort of thoughts on how hospitals and healthcare organizations can talk about this issue of compassion fatigue. You know, what are your thoughts on how we should be having that conversation?
You like to give me the hard ones.
Only the hard ones go to you, Jess.
No, I'm identifying a theme, which I, of course, because this panel is brilliant, and we've been talking about it for a while, the idea that there's not an internal versus an external comms right now, that everything is external, and that we need to be, this is like really shining a light on the fact that we need to double down on investment in our people. I used to say, how do I get my employees to post good things about us on the internet? Well, revisit your parental leave policy, treat your people better, and then I don't have to artificially incentivize them to share things about you on social media. Right now, we're seeing the same thing, that it is a worthy and exponentially kind of beneficial investment to double down on your own people right now. And I love what Allison's been saying about how Peace Health is doing that and focused on caring for caregivers and just communication writ large, transparency from leadership. There's this there's a disenfranchised feeling. There's this abyss that's growing between administration and your clinical frontline or your staff in food and nutrition. And whatever we can do to decrease that distance, I think is a really, really important piece. And continued dialogue and campaigns. We are running recruitment campaigns around mental health. We're having to staff differently, but it does feel like if you don't have moving humans and dollars around into internal comms in a really intentional way is one piece of this. I'm curious what others are doing.
Brian, I'm curious from a hospital perspective. I mean, how have you guys been, you know, both dealing with the issue of compassion fatigue and the stress that these workers are under, but then also too, you know, conveying a message to the public about what you're doing about it?
Sure. I think I'll answer the second part of that question first. We probably haven't done the kind of job we've needed to convey to the public, you know, what we're doing to take care of our folks. But what I can tell you is that Dr. Louis Lowe, who's our Chief Medical Officer, probably 5 years ago, started an effort where they made taking care of oneself a top priority for all providers. And so it was already integrated into the work that our providers were dealing with before this started. What's happened since then has been much more kind of being attuned to the specific providers that are working in these high stress environments, and what Louis and other medical leaders are doing. And not just medical leaders, but even administrative leaders are doing, is they, over the last 83 days, have spent a lot of time actually on the front lines, standing side by side with providers, you know, talking to them, asking them how they're doing, asking them what they need, asking if there's some way that, you know, we could provide them, you know, more support to make sure that they could do their job. You know, obviously the PPE question, you know, is always at the top of everybody's mind. And, you know, we were fortunate to be able to get through a surge without having to compromise our PPE. And I think that was the biggest concern that probably any medical facility had during this pandemic. So we were able to get through that. So that was reassuring to our frontline caregivers. At the same time, part of it has been to make sure that, you know, there have been breaks where people aren't stuck in a high stress environment for long periods of time, and making sure that they're getting out of those areas and that they feel safe, they have a safe place to go when they're not in that environment. We feel like that's helped.
Yeah. Well, Allison, I want to ask you a little bit about this, because this gets to the compassion issue. This is a really bit of a tricky balancing act, because there's now becoming a lot of discussion about some of the decisions that not just hospitals, but state governments made in not allowing patients to have family or caregivers with them who were sick. And it particularly applies to people like, you know, young people and patients with disabilities. And there's a lot of questions now being asked around, you know, is it a violation of a person's rights if they don't have an ability to communicate with a doctor or a nurse about their unique health status or particularly for someone with mental disabilities, that we need to revisit this, that we need to have a conversation around, how do we allow for patient advocates to be part of the hospital care in the middle of a crisis like this. So, Allison, your thoughts on this?
Yeah, I think there's a couple ways that we've been approaching this. There's some direct ways in terms of our government affairs department and really talking with and advocating for how can we align with all of the CDC guidelines and all of the recommendations to protect patients and from the virus and keep visitors safe, and also accommodate and make sure that we're being inclusive and we're meeting people and patients holistically and taking care of them holistically. So while we're advocating for that, with local and state governments, we're also taking the proactive approach internally of giving them tools if they can't be in person. Our technology department we've launched iPads in all of our medical centers in order to have that telehealth and inpatient connection. And so that's been a real connection point where patients are able to still communicate with their family members, and the family members are able to communicate with the providers about what are the care needs, even though they can't be physically. So they're distant, but they're still being able to connect with one another. Another key piece of that is really having our chaplains involved as a Catholic healthcare organization, and our mission services department involved in those critical conversations, especially in COVID units, especially in critical COVID units where we were for the end of life patients, and the accommodations that we're making with following all of the regulations, but using telehealth and our mission services department to give end-of-life patients the respect and care that they deserve.
It's a tricky, very tricky balancing act. And I know that everybody's just been trying to make the best decisions they think they need to make in the moment. Well, I want to talk about a bigger picture issue. There's a couple more questions, and I want to make sure we allow a little bit of time for folks listening in to ask their questions. So in our last 15 minutes, just a couple points, and then we'll open it up. It's no secret that hospitals are having a revenue crisis, and it's largely driven by the fact that there has been a pause on non-COVID related care. So all the things that Brian and Allison, you guys were just talking about in terms of we want to get people back to the hospital that do have chronic diseases, that do need other kinds of care. Now hospitals are in a really tough financial situation. And so, Brian, I'm just interested, how are you talking about the hard decisions now and the sort of second crisis within the crisis that hospitals like Legacy are facing?
I was thinking this was going to be a Jess question. So it's a tough one. No, I'll go ahead and jump into this. So the one thing that we've tried to do with Legacy is we're working really hard to do our best to support and to essentially the people who are providing the care. So we have, one of the first things that happened was when we stopped doing electives, we created a pay code called CSL. Essentially, if you were out of work because we weren't doing, you didn't have work that was available, we continue to pay our employees. In fact, we've paid those employees who haven't been working through tomorrow. So we're trying to keep them there. But at the same time, because of the losses that we're facing, we're having to really look at making some fairly tough decisions. We've frozen our budgets. Any openings that we had other than critical workers have been eliminated. All of those have been cut. We're looking for any kind of federal subsidies that can help make up some of the loss that's been there. I can tell you the people who took the biggest pay cuts are our senior leadership team, including our CEO, who took a 30% cut in her compensation. And so what we're trying to do is we're trying to support those people who are on the front line as best we can, at the same time looking at absolutely everything else. And as a manager of a department, I'm required on a weekly basis to look, are there ways that I could cut costs? And managers across the system are having to look literally at, what are the ways that we can save? In our division, in the community relations and marketing division, we've essentially given up about 30% of our budget for the rest of the year because we know that we have to support the hospital system going forward. At the same time, we're looking at what's happening in terms of the reintroduction of non-emergent procedures and trying to see if we can begin to gain some of that back. But I can tell you from our CFO in an interview I was in with her, she said, there isn't a hospital system in Oregon that's not going to end up in the red at the end of this year. And we know that, we recognize it, we're trying to embrace it, we're trying to minimize it, but we also understand that there's nowhere we're getting out of this without without losses.
So Allison, let's stay on this question because I think this is a really important topic for us to discuss as communicators. Allison, I'm interested in your perspective. It seems as though there's a perception amongst the public that maybe is at risk of shifting the public trust and support of hospitals that we have now to sort of more of but aren't hospitals these big, wealthy institutions that make all this money, and how could they possibly be in financial distress? Like how are you balancing the reputational trust and credibility that you have now with the potential challenge of people not understanding, how hospitals generate revenue and the impacts that this crisis has had on that revenue?
Yeah, great question, Zach. I think that it starts with, we're a not-for-profit organization. We are a community partner with all of our communities in providing a needed service. While patients come to the hospital or the clinic and have an urgent need, we are also proactively supporting our communities in various ways that extend beyond our operations, beyond the strategy or the brick and mortar building. A good example of that would be all of the work that PeaceHealth has done to support skilled nursing facilities. With more than 2,200 patients and 38 skilled nursing facilities across the states. The skilled nursing facilities don't belong to PeaceHealth. They're not a part of our organization, but they're a critical community member and a critical partner that we know we need to support. We know that they're vulnerable. We know that they're at risk. They don't have the support that they need to care for their patients. So this isn't about PeaceHealth budget profit in this environment. It's about keeping our community wellness centers, our community health centers afloat so we can continue to care for the community. And I think going back a little bit to what Brian was saying too, and about this ties a little bit back to the compassion fatigue piece, which was starting at the beginning with our caregivers and making sure that they're being cared for spiritually, emotionally, financially, all those things from childcare needs to finances, to their mental health, taking care of them holistically in that way in the beginning, that now when we're in a place where we're asking things like Brian was mentioning about executives taking pay cuts, taking care of you in the beginning to then ask you to take a temporary pay cut or use your extra PTO to help the organization financially is a really strong communication thread that we have to continue to weave, demonstrating that it's not just lip service. We care for you and are providing all of these services for you and hope that you will help the organization stay afloat as well, because we're all in this together.
I want to jump really quickly to one last thing. I'm going to give each of you a minute. It's going to be like, the wrap up on live TV where you're like, you have 1 minute to answer this question. It's a big question. It's a big question. So Piseth, I'm going to start with you. Now the conversation is starting to look more at, okay, we feel as though maybe we're in a position to say the words, we feel like we maybe have our arms around this. But what about a second wave? What happens when, there's a reemergence or, new pockets of pandemic that sort of begin to pop up going into the fall? So I want to ask all four of you just thoughts on talking about, planning for, what's ahead. And Piseth, we'll start with you.
Yeah, that's a great question. When the initial stay-at-home order was enacted in March, we saw a very slight dip in overall call volume, but what we actually saw in relation to that was big spikes in specific types of calls. So when you start looking at the structures and routines for folks, coping mechanisms as they're managing some of their diseases, chronic illness, and as Brian mentioned, as people were waiting longer and longer to seek help, we started seeing more exacerbated signs and symptoms and issues. As we begin this reopening, Thankfully, we're measuring our data and looking at those call types so that we're doing as best we can to kind of realign our priorities and strategies to deal with what we anticipate are going to be big spikes again as we reopen.
Yeah, I'm going to Brady Bunch this because you guys are organized like the Brady Bunch on my screen. So Jess, I'll go to you. Final thoughts.
I have a slight sense of optimism that kind of public awareness of how the system is broken at a larger level and the financial model that underpins us, that there's a raised awareness about that, and that clinics that were only had 30 days cash in hand are now thinking we should probably have 90 days cash in hand. I mean, there's a lot of good key learnings there about just how we're operationalizing and prepping financially, and then doubling down on access, digital divide, telehealth promotion, and internal comps, just kind of continue to beat that drum. But I think some of our smaller clinics, arguably, it's more dangerous. We're on the red. We don't have as much cash in hand and kind of large institutional support, but they've also been able to be more nimble. And so I think everybody's kind of responding and learned a lot depending on where they live in the ecosystem here.
Allison, how are you guys at Peace Health preparing for the potential for a next wave?
I think it's a lot of if-then scenarios. We know what we learned from the first wave and from what we anticipated we would need for PPE and what we actually needed, supplies, all of those things, staffing. The things that we could not have imagined in a million years had we had given all the scenarios possible. But now we have a lot of scenario options and are preparing for those appropriately based on what we learned from the first wave and deeper in the if-then waves. Well, what if we run out of that thing? Then what's the next step? And multiple of those down, knowing that it can change at the drop of a hat with a supply chain variance.
Brian, you get final thoughts.
Yeah, thanks. Ditto to what Allison said. I think I can tell you, I had said earlier that our EOC closed down officially yesterday afternoon, but what I can tell you is it's gone virtual. We're not physically meeting anymore, but we're continuing on. We've got a daily call that we're gonna stay on all the way through the fall because we are in fact anticipating that there will be a reemergence and actually planning on it actually being worse. In the sense that, you plan for the worst and hope for the best. I can tell you our supply chain folks are working diligently to try to make sure that everything we need is in hand, that we're ready to go. I think the one concern from a societal standpoint that a lot of people that I know here have spoken about is people will fall into sort of a complacency. It's like, yeah, well, they said there was going to be this big surge and there was going to be all these deaths, and guess what? There weren't, and we did really, really well. And when the second wave comes, will there be sort of this sense of, hey, it wasn't that bad last time. What's the big deal? And my concern is, and I think the leadership concern here is that we're going to run into the same thing in the fall.
Yeah.
Or we're going to run into that in the fall, and the thing that we didn't experience now may occur in the fall.
Yeah, Brian, that's a great point. There's nothing harder to explain to the public than a crisis that doesn't happen. And I think we're in a very strange and unique place here in Oregon in that yes, we had a crisis, but we did not have the New York City crisis, right? We didn't have the same level of pressure on the healthcare system that I think a lot of us feared, and a lot of the decisions that were made were kind of based on. So that's a very good point. I want to open it up to, we've got a couple of questions. We probably have time for just a couple questions, and I've got a few things flashing on my screen here. Oh goodness. All right. So this is the hardest part of moderating, is now I've got to find a good question amongst a lot of good questions. Here's one, and let me just read this. So as a city councilor, we are slowly opening parks and trails, but we're still keeping playgrounds closed for the time being. How has the group dealt with the kids aren't vulnerable argument? And maybe Paseth, as a first responder, you want to start with that one. How are you guys talking about the sort of perception that, kids are going to be fine and we don't need to worry about them out there playing?
We are largely relying on our healthcare partners so that we have a unified message. As we talk about these types of questions on our joint information system, regional PIO calls, we want to make sure that we're aligned and we're speaking appropriately. From a first responder standpoint, pediatric patients tend to compensate very, very well for a short time, but then they crash hard when things get really bad. So we're really trying to encourage as best we can to limit exposure, stay at home, follow those orders so that they're just minimizing their risk.
Yeah, I want to get to a few others of these, and people this time are asking specific questions to specific people. So Jess, this is a question for you. What in particular made you notice the digital gap and move to radio and billboards? You'd made reference to this earlier in comments.
I work with a lot of organizations that serve an aging population who is not digital native and doesn't even have a desktop at home. And we talked about, do we need to call the Geek Squad at Best Buy and go deliver with Meals on Wheels some freaking computers and then hope that their kids can teach them how to access telehealth? I mean, we've been trying to solve this in very physical, weird ways. The other one is I work with folks that serve underinsured and uninsured patients, refugee communities, immigrant communities, folks that don't have access to the same technology that we all assume were ubiquitous and certainly don't have some of the same language needs, or like we've talked about, different developmental needs. So the patient populations that my clinics are working with immediately were the most vulnerable and exposed during COVID, which required a really strong pivot and still is requiring moving money and strategies over to continue to better serve them. So again, optimism is that this is a drum that we continue to beat and we continue to prioritize these folks in a way that we weren't before. So a good thing, kind of.
Yeah. Well, I'm going to do one more question, and I apologize. There's tons of great questions coming in here, and I encourage folks to reach out to each of our panelists if there's specific questions they'd like to talk about offline. But here's one for Allison and Brian. How do you think we should change state and federal communications training procedures to incorporate the learnings that hospitals have gained from this process?
Ooh.
That's great. Allison, you want to jump in, or I'd be happy to start?
It's all yours, Brian.
Oh, thank you. Thank you very much. The thing that would probably be really important to be able to do is, I think we need to have one big debrief. We need to figure out a way to do one big debrief. I can tell you internally we're doing that. We're doing an EOC debrief. Our entire comms team, internal, external, digital, we're doing a debrief. We're going to do lessons learned. It would be nice if there was a repository somewhere where we can talk about things like the lessons that we learned. Internal communications, a great example. There was sort of this initial push where everything, as Paseth said at the very beginning, where we're sort of relying on this email and an intranet page with lots of information on it. And then, somebody says, hey, wait a minute, 70% of the 14,000 people who work for Legacy Health aren't sitting in front of a computer. How do we get that information in front of them? That's a great lesson in terms of how do we convert that information in a format that we can put it in front of people who aren't looking at it the same way that we are in terms of from an administrative function. So if there was a repository where we can put these lessons learned, I think it would be really great.
Allison?
Yeah, and I would just add, I think similar to our approach with having a system and network hospital incident command stood up, the greater incident command structure is really challenging when it can be hyper-localized in a community, it can be statewide. When you're in Vancouver, Washington, and Portland, Oregon, it needs to cross the border. It can't stay in its own state, and that got really complicated as well. So I think greater integration through in operations with state and federal would be ideal.
Well, I want to just go back to something real quick. This is a great, I think, way to end this and sort of bid our audience good Memorial Day weekend. I just want to read this. And Allison, I'm so glad that you included this, but this young man by the name of Dominic, blessings from the front lines. I think these are good words to end with. When the light does not seem bright, There are undercover heroes who fight. We will continue to sit tight, even if it's night after night. Thank you to all of the frontline heroes that fight. So thank you all for joining this conversation. Paseth, Jess, Allison, Brian, thank you for contributing to the dialogue here. This is tough stuff. We don't have all the answers. We don't have it all figured out. Hospitals are pillars of the community, and we really appreciate you guys coming in and talking about these issues today, and wishing everybody a great weekend. So thank you guys very much.
Thanks,
Thank you,
Zach.
Zach.
Thank you, Zach.
Bye,
Take care.
everybody.
Bye, everyone.
Bye-bye, everyone.
Wear a mask.